So hello and welcome to iTeniv's webinar. Today we're going to be presenting on EHR cloning. This is our third webinar in our Government Regulations and Ramifications series, and this is the 17th installment of our educational webinar series. My name is Chelsea Grover, and I'm the Marketing Communications Coordinator for iTeniv. I'd like to take a moment to explain the process for today's presentation. First, I'd like to mention that the webinar will be recorded. Next, I'm pleased to announce the dates of our upcoming webinars in this Government Regulations and Ramifications series. The next one is on December 2nd, and it's going to cover the dangers of information blocking and its effect on interoperability, where we will help you discover if you are the victim of, or perhaps even participating in it, common practices, and how to combat it. Our final one in the series will be on high-tech security and HIPAA, and it's on December 16th. Either register now on our website or keep your eyes out for the webinar invitation email from us. At the end of the presentation, we're going to open the floor up to questions from you. We will answer all the questions at the end, but you may type them in the questions area of the webinar control panel whenever they occur to you. For your reference, we will also be emailing links to the recording and PDF of the presentation later this week or on Monday, as we do with every webinar. Finally, for audio clarity purposes, everyone's phone will remain muted throughout the entire webinar. If you experience audio issues, please let us know so we can resolve them in the chat box. And again, questions may be entered in the questions box. So without further delay, I'd like to introduce our presenters for today. Lindsay Lanning, Cindy Kincaid, and Kathy Thompson. Lindsay Lanning originally joined us from the Ohio State University intern program, where she was getting her degree in Health Information Management Systems. After graduation, Lindsay joined our team as the Healthcare Informatics Coordinator, where she spends her time immersing herself in the ever-changing healthcare IT environment and educating the rest of the company on new issues and trends in the industry. Kathy Thompson has been with iTeniv for 10 years. Prior to joining iTeniv, she was a medical assistant at a neurosurgical practice. This is where she got her first taste of NextGen and has been hooked on it ever since. Currently, she is managing consultant at iTeniv, where she specializes in NextGen EHR and government incentive programs. Cindy Kincaid is Vice President of Consulting Services at iTeniv and is a certified practice management executive. With over 25 years in the IT healthcare industry and 9 with iTeniv, I think it's fair to call her a subject matter expert in everything NextGen. She's had the honor of being speakers at many past MGMA and NextGen user group events. Okay, so Lindsay, I'm going to go ahead and pass the webinar off to you. Feel free to get started when you're ready.
Great, thank you, Chelsea. All right, first of all, everyone, thank you for coming. Today we'll be exploring the fine line between efficient documentation methods and EHR cloning, a threat to documentation integrity. Various government agencies are against it, auditors will recoup payments for it, and the FBI may even pursue you for it. But vendors advertise it and physicians love it. So what is it and how do we protect against it? Well, today we're going to define EHR cloning, identify the benefits and risks of using the copy and paste functionality, including the ramifications of EHR cloning, examine how to define, support, and execute best practices to avoid EHR cloning in the NextGen EHR, and identify auditing best practices. So what is it? Well, CMS and AHIMA define cloning as cutting and pasting previously recorded information from a prior note into a new one. The use of copy and paste allows past notes or portions of notes to be pulled forward into the documentation for a current visit. This function provides the ability to reuse all or parts of a detailed narrative information within a single patient's record or across multiple patients' records. This includes functions that pull in specific identical data elements. And the Office of Inspector General says, copy-pasting, also known as cloning, allows users to select information from one source and replicate it in another location. When doctors, nurses, or other clinicians copy-paste information but fail to update it or ensure accuracy, inaccurate information may enter the patient's medical record and inappropriate charges may be billed to patients and third-party healthcare payers. We can see these definitions are very similar, but CMS and AHIMA focus on pulling identical information forward, whereas the OIG focuses on the failure to update the information. I like the OIG's definition of EHR cloning better because it really gets to the essence of what EHR cloning is, because it's not just copying and pasting. It's the act of replicating data combined with the failure to update it and verify its accuracy. EHR cloning is being used interchangeably with copy and paste in these definitions, but I do want to point out there's a difference between them. So EHR cloning versus copy pasting. EHR cloning is often referred to as copy pasting, but there's a difference. Just because you copy paste does not mean you are performing EHR cloning. As long as you make modifications to the EHR documentation after you copy and paste it, it is not considered cloning. So if you sign the note and say, that's what I saw, that's what I said, and that's what I told the patient to do, that's what you're swearing to. And then no matter what you copy and pasted, if all the information is true and up to date, then you're fine. The problem comes in if you don't have the time to read it and you pull information forward without reviewing it. I mean, it's copy-paste. This is a digital cultural norm. I copy, I paste. I did it multiple times in this presentation just to help move things around when I was setting it up. This particular shortcut is so deeply embedded in the documentation creation process that it almost takes on a reflexive nature. It feels comfortable and normal, and it saves a lot of time. So who cares if physicians use it in the medical record? Well, when copy and paste leads to EHR cloning, a lot of people start to care. And we're going to take a look at how relevant this topic has been over the past 3 years. EHR cloning in the news. So these 4 major reports released by federal organizations are just a few of the countless examples of anti-EHR cloning sentiments expressed over the past years. These examples show the widespread attention this phenomenon is receiving, the seriousness at which this threat to documentation integrity and patient safety is being taken. The Department of Health and Human Services, the Centers for Medicare and Medicaid Services, the Office of the Inspector General, and the American Health Information Management Association have taken a firm stance against EHR cloning. On September 24, 2012, Secretary Catherine Sebelius of the Department of Health and Human Services and Eric Holder, Attorney General of the Department of Justice, issued a joint letter to several healthcare associations. Although the letter applauds the widespread adoption of EHRs, it notes that there are indications that some providers are using them to clone records and to game the system. The letter points out that this type of false is not only dangerous to the patient, but it's also illegal. The letter states that they plan to pursue healthcare providers who misuse electronic health records to bill for services that were never provided. In December of 2013, the Office of Inspector General published a report titled, "Not All Recommended Fraud Safeguards Have Been Implemented in Hospital EHR Technology," which gave some insight into EHR technology audits and access control capabilities and how healthcare providers are taking advantage of these functions. A report released in January of 2014 from the Office of Inspector General and the Department of Health and Human Services found that the Centers for Medicare and Medicaid Services and its contractors have adopted few Medicare program integrity practices to address vulnerabilities in electronic health records. These vulnerabilities include fraudulent billing practices like copying and pasting or cloning and over-documentation. They recommend that CMS provide better guidance to Medicare contractors on detecting fraud in EHRs and direct those contractors to use providers' audit logs, a valuable fraud detection tool when reviewing medical records. And lastly, in March of 2014, AHIMA released a 7-page advisory titled Appropriate Use of the Copy and Paste Functionality in Electronic Health Records. This advisory expressed AHIMA's position on the use of copy-paste and provided recommendations for industry stakeholders, EHR developers, and healthcare provider organizations on what should be done to protect against EHR cloning. Bottom line, this isn't going away, and there has been even more attention directed at EHR cloning as a potential threat this year, specifically by organizations such as HIMSS and various healthcare news websites that report on the latest updates and issues in the healthcare industry. So like I said, EHR cloning has been targeted, and you may be asking why. Well, EHR cloning is considered so detrimental because of its extreme likelihood it will lead to Medicare fraud. It can result in a misrepresentation of the reason for the patient's visit and cause fraudulent billing claims. Template notes of many EHRs will be audited because the notes often include copied and pasted text and omit the nuanced information that is critical to truly meaningful documentation. Just to get a good idea of what I mean when I say EHR cloning is being targeted, I have included an excerpt from the letter released by the DOJ and HHS that focuses on the consequences and efforts to identify and punish EHR cloning. So this letter underscores our resolve to ensure payment accuracy and to prevent and prosecute healthcare fraud. A patient's care information must be verified individually to ensure accuracy. It cannot be cut and pasted from a different record of the patient, which risks medical errors as well as overpayments. The CMS is specifically reviewing billing through audits to identify and prevent improper billing. Additionally, CMS is initiating more extensive medical reviews to ensure that providers are coding evaluation and management services accurately. CMS has the authority to address inappropriate increases in coding intensity in its payment rules, and CMS will consider future payment reductions as warranted. We will not tolerate healthcare fraud. Law enforcement will take appropriate steps to pursue healthcare providers who misuse EHRs to bill for services that were never provided. The DOJ, HHS, FBI, and other law enforcement agencies are monitoring these trends and will take action where warranted. Now, a statement from CMS regarding its policy on EHR cloning. When documentation is worded exactly like or similar to previous entries, the documentation is referred to as clone documentation. Whether the clone documentation is handwritten, the result of a pre-printed template, or from the use of an electronic health record, cloning documentation will be considered misrepresentation of the medical necessity requirement for coverage of services. Identification of this type of documentation will lead to denial of services for lack of medical necessity and recoupment of all overpayments made. And finally, AHIMA's position on EHR cloning states that the use of the copy and paste functionality in EHRs should be permitted only in the presence of strong technical and administrative controls, which include organizational policies and procedures, requirements for participation in user training and education, and ongoing monitoring. Users of the copy and paste functionality should weigh the efficiency and time savings benefits it provides against the potential for creating inaccurate, fraudulent, or unwieldy documentation. So in case you missed the one common thread that bound all of these organization statements together, let me point it out. In each of these statements, there was an underlining warning of punishment if discovered to have been cloning documentation within the EHR. So let's go over the consequences they each mentioned to get a clear understanding of what a provider could face. First off, providers are subject to audits and medical reviews. And no, for those of you who just attended our webinar last week, I don't just mean meaningful use audits. I'm sure you are all familiar with the Recovery Audit Contractor Program, or RACS. The Recovery Audit Contractor Program's mission is to identify and correct Medicare improper payments. It divides the United States into 4 geographic regions and uses contractors to review, audit, and identify improper Medicare payments in each of those jurisdictions. Contractors are paid on a contingency fee basis, receiving a percentage of the improper payments they collect from providers, which means overpayments from upcoding caused by EHR cloning that are recouped end up benefiting the contractors directly. So if found guilty of EHR cloning, a provider is at risk for recouped payments as well as being pursued for healthcare fraud. Keep in mind, Medicare carriers and recovery audit contractors have the authority to pull medical records up to 3 years old if they suspect any fraud or abuse. And Secretary Kathleen Sebelius expressed serious concerns that some providers are misusing EHRs to increase reimbursement by cloning medical record documentation and upcoding visits, and warned that she will not tolerate healthcare fraud and will take steps to ensure payment accuracy. So what is healthcare fraud exactly? Fraud means an intentional deception or misrepresentation made by a person with the knowledge that the deception could result in some unauthorized benefit to him or herself or some other person. This includes anyone who does not ensure that material cloned, scribed, or auto-populated is an accurate representation of what he or she as the provider actually did. And along those same lines, medical negligence occurs when a healthcare provider injures a patient by failing to provide a standard of care. When actions or lack of actions are done in a negligent manner that results in injuries, the healthcare provider may be held liable for those injuries, including the medical treatments necessary to help correct the new injuries that have occurred. This includes failing to ensure that material cloned, scribed, or auto-populated is an accurate representation of what he or she as the provider actually saw, heard, and prescribed. Healthcare fraud truly can be as easy as hitting Control-C, Control-V while in the EHR. And what we see happening here is that all of these negative consequences come back to one person, and that's the physician. So now that we've gone through what EHR cloning is, how it's being addressed in the healthcare industry today, and the negative consequences it can have on physicians, Let's look at why this is such a big concern. Let's dig deeper into why those healthcare organizations are having such strong reactions to EHR cloning, and how we can walk the fine line between cloning and documentation efficiency. So like I said before, the consequences of EHR cloning, it all comes back to one person, the physician. So it's important to fully realize it is the physician's responsibility. EHR cloning can place providers at risk of complaints of billing fraud and, of course, medical negligence. As the provider of the medical record for the patient, they are responsible for the contents of the medical record for any service provided. It's imperative to remember the provider is the one doing the explaining of why fraud or medical negligence was committed. Since the content of a medical record is the physician's responsibility, and again, it's the physician who has to face consequences of EHR cloning, it's obvious we should look at the perspective of the physician on EHR cloning. Well, providers see potential cloning tools as time-saving features of EHR systems and consider them to be very important as EHR users. It is one of the advantages of digitalizing health information and cuts down on documentation time. Currently, the federal government is using financial incentives and penalties to push physicians to adopt EHR technology. With its auto-populated templates and standardized visit types, this technology removes the heterogeneous nature of clinical information. So before EHRs, the issues seemed to be variation in medical records. But now, with these EHR templates and auto-populated fields, there is an overwhelming sameness that is being viewed by some as a bad thing. So now physicians are being forced to re-engineer variation into their records, simply to pass audits and other compliance tests. This is a catch-22 for providers, and if we take on their perspective, we can understand why this situation and the issue of EHR cloning can be frustrating. At some point, however, EHR efficiency does cross the line into EHR abuse. It's identifying where that line resides that's the challenge. So to identify where you are as a practice regarding EHR cloning, take a step back and analyze your current status. Look at the policies and procedures in place regarding copy-paste or pulling forward information in your EHR system. Are there any? Do they need to be updated? Look at what your physicians are currently doing. How are physicians documenting information? Are they copying and pasting or pulling information forward without making changes? Or are they utilizing these features while making sure to chart any changes afterward? Or are your physicians just not using any of these potential cloning features in the EHR? Once you have the answers to these questions, identify the areas that are at risk or the features in your EHR that could lead to cloning, and then take actions to mitigate them. And lastly, never stop paying attention to EHR cloning. Make sure to have ongoing oversight of this issue through a robust audit program, which we will cover later on, but also through education and training programs for clinicians. Education and training for clinicians should review organizational policies on copy-paste and documentation, review sanction policy, review the audit policy, and train the user on EHR workflow for accepted copy and paste entries. It may be the physician's responsibility for the content found in the electronic health record, but it's our responsibility to make sure clinicians are educated and trained on EHR cloning. There are other ways to protect against EHR cloning. There are some EHR software features that will help preserve EHR documentation integrity, such as user authentication and access management, a robust and complete logging and auditing function, data entry editing with options to verify validity of information on entry when possible, controls and limits in automatic creation of information, and the ability to monitor corrections and additions to the medical record. We can also look at alternatives to copy-paste or carrying forward documentation in order to prevent cloning. Some alternatives include dictation or transcription. Instead of copying and pasting a past note, dictation is often easier for the provider and will save time. The use of a medical scribe who will be able to document for the provider. Templates, which include drop-down menus and checkboxes that can be used to save time documenting, but should be updated with each patient encounter. Macros, which are phrases that are used routinely and can be populated automatically that speed up documentation, but are used in addition to patient-specific information for that encounter. You can also cite different aspects of the medical record, such as active problem lists from the current problem list, or current medication, allergies, or even labs. Providers are just looking for a balance between the time savings that copy and pasting could afford, such as updating routine demographic information and unchanged clinical conditions, and inappropriate uses that could jeopardize patient care or lead to billing fraud. And these alternatives provide ways in which clinicians can achieve faster documentation without the risk of cloning. Now, if none of those alternatives sound like they will work for you, MGMA has identified chart notes that may be appropriate for copying and pasting. These notes should include information pertaining to demographics, medications, allergies, problems, and labs. These areas often contain information that does not change, and therefore would be appropriate to carry forward or copy and paste information as long as the provider reviews the documentation to ensure its accuracy. Now, the inappropriate uses of copy and paste that would likely lead to EHR cloning would include having two charts open at one time, cloning information between the two, copying an office visit into the next 10 visits, using copy-paste for an extremely long chart note documentation not unique to the visit, and billing multiple times for one procedure. It's important to review the service that was provided and bill accordingly. So these inappropriate uses of an EHR could lead to unfavorable consequences and stir up quite a few concerns. One of these concerns is that cloning can result in potentially harmful activity, prone to error and confusion. It can lead to seriously detrimental unintended consequences, including fraudulent documentation, the inclusion of outdated information from previous notes, redundant information, and confusion over who has authored the most current note for coordination of care. It's important to realize the medical record must contain documentation showing the differences and the needs of the patient for each visit or encounter. When clinical staff members clone information but fail to update it or ensure its accuracy, inaccurate information may be placed in the patient's medical record, and inappropriate charges may be billed to the payers and/or patients. Also, inappropriate cloning could facilitate attempts to increase the information and create fraudulent claims by copying a higher billing code than necessary from one visit to the next, or repeating a service that was provided during an initial visit but not during the subsequent consult. So while many providers use these cloning features as a time-saving measure, the risk of creating significant errors or outdated documentation often outweighs the benefits. This is why practices should be careful to institute strong technical and administrative controls to prevent the misuse of available EHR tools. So let's take a minute and recap the risk to documentation integrity associated with EHR cloning as identified by AHIMA. And they are inaccurate or outdated information, redundant information, which makes it difficult to identify the current information, inability to identify the author or intent of documentation, inability to identify when the documentation was first created, propagation of false information, internally inconsistent progress notes, and unnecessarily lengthy progress notes. Now that we understand what EHR cloning is, the consequences associated with it, and the threat it poses to the integrity of a patient's medical record, let's look at specific features in NextGen that increase documentation efficiency, but do possess the potential to cause EHR cloning if not used properly by a physician. For this section, I'm going to go ahead and turn it over to Kathy Thompson, who will walk you through these NextGen specific features and best practices.
Next, potential NextGen EHR cloning features. Potential EHR cloning features, Quick Note and Quick Save. NextGen describes Quick Note as a way to reduce the repetition associated with entering information for large numbers of similar patients presenting with similar symptoms and conditions. It allows the provider to save common visit types to reuse and then chart by exception. In theory, this, along with Quick Save, would be considered a facilitator of EHR cloning since you are using a function that pulls in specific identical data elements. If the clinician is successfully reviewing the information and charting exceptions, then it is not considered cloning. But if it is identical information and repeated continuously, it would be. Different ways to use quick saves. There are different ways to use default quick saves in NextGen software. When used properly, the physician would use the globally normals and then chart by exception, information specific to the patient. When used in a cloning scenario, the physician only uses the globally normals and does not chart by exception based on specific patients. For example, the physician chooses the PE globally normal default and also charts the patient-specific findings, such as swelling, etc. This is charting by exception. An example of potential cloning is the physician chooses the physical exam globally normal. Though there are specific findings for each patient, the physician only charts the globally normals using the defaults. The results will be every chart has the same physical exam findings regardless of the patient or their conditions. This is not charting by exception. Review system defaults. Example of a review system default list, which is specific to the review systems and not the entire encounter. Each user has the ability to save defaults. Once they are saved, they appear in the list for use, as shown in the screenshot in the PowerPoint presentation. When used, they will pre-populate fields on the template with values that have been saved in the default. Template default examples. Saving defaults and quick saves to avoid cloning. Use the Save Current Only radio button. When using Save Current Only, just the pop-up data will be saved for the globally normals the user will need for the physical exam, review systems, etc. Examples that can result in cloning. Saving multiple templates or entire encounters as a quick save visit. Saving patient-specific data as a default. For example, a lab value on a template. If the template is saved with that lab value as a default, it could potentially save when used over and over again with that specific default. Methods to prevent EHR cloning in NextGen. Run frequent reports. Ensure that the system practice template includes your NTD fields. NTD fields are fields the practice does not want providers to save in their defaults. Ensure the proper use of quick saves, template defaults, and my phrases. Use default lists specific to a template and not to an entire encounter. Preventing certain fields from being saved into a quick save. To prevent fields from being saved into a quick save or default, the admin at the practice can add the table and field name into the NTD fields on the NG-KVM template defaults so they are not included when defaults are saved. Carry forward fields. You will not see very many carry forward fields in NextGen currently because it can be considered cloning. If a provider tries to carry forward an exam from a previous encounter over and over again without any changes made, it would be considered cloning. For example, if a provider saw a patient a month ago and they carried forward their previous encounter to today's encounter and did not make any changes, this could be considered cloning. It would absolutely be considered cloning if the provider did this from the first time they saw the patient through all subsequent encounters thereafter. My phrases. Throughout NextGen, there is a feature for end users to save my phrases. This functionality allows physicians and end users to save frequently used verbiage. When used properly, the user will select a my phrase as part of their documentation in addition to specific documentation on the patient. When used improperly, a user will document only my phrases when charting patient to patient, chart to chart, without any modifications or details specific to the patient and/or encounter. Fill in the blank notes. This is an example of a note that is very close to cloning. The note provides fill in the blanks, so it is not cloning. However, if the note did not have any blanks, Basically, if it was a full document and was used repeatedly across patients and encounters, it would be considered cloning.
Great, thank you, Kathy. So after talking about NextGen, it's important to point out there should be a joint responsibility between users and developers of EHRs to ensure that record systems can be configured to appropriately handle copy and paste functions, including recording copy and paste user actions, audit capabilities, and reporting. So we keep mentioning audits as a way to protect your practice against the negative consequences of EHR cloning, but we haven't considered the specifics of what an audit program should look like. So let's explore best practices to audit against cloning. First off, it's important to understand how RACs identify cloned medical records during an audit. While some things may not change significantly from visit to visit, for example, the bulk of the patient's history may remain the same, other areas of a patient's EHR are rarely static and point to evidence of EHR cloning if they are identical. These areas include the patient condition, the interim history, vital signs, symptoms, and treatment. It's important to remember that once one part of the medical record is obviously wrong, the auditor is likely to discount the record in its entirety since it's impossible to tell what is and isn't accurate. So it's extremely important that providers and practices are able to audit against cloning in order to prevent payment recoupment from external audits and avoid healthcare fraud accusations. So we suggest that you perform self-audits or have a consultant audit your practice regularly to ensure that your EHR is coding to the correct level of service, thoughtfully and appropriately manage copy functionality by establishing sound documentation integrity policies. If organizational policy bars the use of copy and paste, but the system supports that action, the organization must decide how this behavior will be monitored and measured. And finally, make sure the use of the copy functionality is accompanied by the ability to review, test, audit, and approve. Going off that last bullet, that the use of the copy functionality should be audited, I've included the government standards for an EHR's audit log, which must capture the date and time of a change or use of the record, identify the patient, identify the EHR user, identify the type of action, such as printing or copying data, submitting data queries, or entering, revising, or deleting data, and identify the patient data being accessed. So you may have your EHR's audit log in place and ready to use, but in order for this to be effective, you need to develop an audit plan. Organizations can develop an audit plan by first determining the following: how and when audits will be conducted, who will perform the audits, the frequency for performing the audit, the time period covered by the audit, how the sample size will be determined, how to describe outcome indicators, and how copy functionalities within the record are to be identified. We will now dive into auditing against cloning in NextGen. At this point, I will hand it off to Cindy Kincaid, who will take you through the NextGen specific auditing tools available to you.
Hi, everyone. Okay, what we're going to talk about specifically are reports and auditing against NextGen. As you know, we've kind of pointed out in this presentation that NextGen, if used with all of its features and functionality, can become a cloning tool, and that's not its intent. NextGen makes that very clear in many of its presentations and training. However, we want to talk a little bit about how you can avoid it, because obviously you put a temptation in front of someone, they're in a hurry, everybody has the best intentions, but sometimes things can go awry. The biggest way to audit against cloning within NextGen is to use the report. Reports can be created based on the fields the practice has saved for the defaults to be sure the defaults are not pulling any patient-specific data as opposed to the general values. We talked a little bit about that. You could change those, you can control that in your system practice configurations and make sure that everyone is on board with that. Make sure that when you are setting these ideas up and you're putting the quick saves or the quick visits in place, that you have really worked with your compliance department. If you don't have a compliance department, you typically have someone in your practice that's going to be in charge of compliance.
make sure that everyone's on board with this and that you're making sure that your providers have this. Some of the different report types that we've could talk about is the amount of time taken to document a patient can be tracked. So if you're sitting there and you're doing a 99214 or you've got a high-level office visit and it only took 7 seconds to document, probably a good idea that that wasn't very personalized. A little bit of an extreme, and sometimes there's other things that you can do. Also in the audit utility, it is possible to audit whether or not changes were made after the quick visit saves were chosen. So you run that, you see that they chose the quick visit or the quick save, and then realize that nothing was changed. That's also something you might be wanting to take a peek at. Some other examples that we might be talking about is that if you are running reports and you find that there's a significant amount of codes that a certain provider is generating that were higher level than they were doing before, and there was no education process underway within your practice. That's another example to take a look at. If we continue to look at different report types, you could take a look at the defaults that were saved, what fields were saved in the default, what users have access to create defaults, what users created the defaults. And what we did here is we gave an example of a SQL query that we generated from one of our clients that basically takes to verify the current defaults and take a look at what was done and is there any patient data in the defaults, etc. So that's something that we've done in the past. There are a number of SQL queries that we've worked with on behalf of various clients that are taking this very seriously, but at the same time want to give their providers the ability to use the tools available to them. It's a real challenge to make sure that we keep these things going in the proper direction and at the same time not continuing to penalize our providers with difficulties of trying to avoid these items. So as we finalize the webinar, I want to talk a little bit about the thin line. As we've said, there's a thin line. The thin line between efficiency and cloning can be like walking a tightrope. You have to look at everything. You have to have an internal audit policies. You have to be able to make sure your providers are trained and that they understand. Your compliance department has to be in place. You have to have self-auditing. We can give you all kinds of ideas on how to do that, because when armed with a strong compliance department, policies in place, and provider training, you can successfully walk this line. And it's very important that we all do, because as we move forward into EHR territory, this is only going to become more and more prevalent, and we're going to always be looking for better ways to make this bond between efficiency and the provider and patient satisfaction. As we're closing the webinar, I do want to talk about if you need help, we have a customized EHR health checkup that we're offering. It's a 3-day on-site consultation offering the subjective, objective assessment and plan. We'll interview your staff. We'll run through clinical workflows. We'll diagnose the condition of your EHR, including perhaps taking a look at these options. And then finally, we'll provide a detailed report of the findings and recommended treatments. If you're interested in that, please feel free to reach out to me, Kathy, or Lindsay, and we'll be happy to take you through what that might entail. So now we'll open it up for questions.
Okay, thank you, ladies. That was great, and thank you for sharing all that wonderful information. I'd like to remind everybody that we will be sending out a recording or a link to the recording as well as copies of the slides either tomorrow or Monday, so keep your eyes out for that. Also follow us on social media, Facebook, Twitter, LinkedIn. We post all of our recordings and everything on there. Cindy, when your phone's unmuted like that, it's pretty garbled in the background. Thank you. Okay, so the first question, and again, questions can be entered in the questions area of the webinar control panel. So first questions, what happens if we suspect our practice has patient-specific data saved in our defaults? Cindy, do you want to answer that?
Yes, and Chelsea, I am on headset because Kathy and I are both here, so I hope everyone can hear me. What we've done in that case particularly is we've had practices come to us with a concern that maybe they're coming on board with this a little late, and many of the quick saves and things that have been created were done in advance of their really understanding the rules and regulations associated with cloning. And we have written scripts or SQL reports, or can help a practice if they have, SQL experts on staff that can do that, because it will require a SQL report to do that. There's no standard report within NextGen. And basically, we just look for certain fields that you don't want copy and pasted in your quick saves or quick visits, and then identify those so that you can go in and make those modifications. If you only have a few quick saves and quick visits and have the ability, this is also something that could be done manually, but it would be time consuming because you would have to look at each one of them to make sure it's not there.
Okay, thank you, Cindy. Next one, Kathy, maybe you can take this. Would it be considered cloning if our providers are using a select all feature when documenting in NextGen?
No, again, it goes to what I previously spoke about. If you're using a select all functionality, then it's fine as long as you're charting by exception. As long as you're looking at what you've chosen as your select all, and if the normal or if it's a yes-no type of select all is correct to that specific patient, you can move on. But you want to make sure you're checking the data integrity of what you're selecting, and any of those select all defaults need to be changed, that you're changing them.
Okay, thank you. Next question. We would like clarification. If our providers are copying and pasting in NextGen, are they automatically considered to be cloning? Lindsay, do you want to take that one? Lindsay, I think you're muted.
Actually, I think I'm going to grab that one, Pat.
Okay.
I'm going to go ahead and grab that one. Basically, okay. It all comes down to the fact that you can copy and paste as long as you're reviewing the data and are making changes pertinent to the patient. It's going to be very rare. You can have a quick phrase, or even in dictation, if you're looking at describing a particular symptom that maybe is the same for every patient all the lines. But there's always going to be something unique about that patient. And the recommendation is take your baseline, put it in there, and then go in and make an adjustment of some sort that's specific to that patient. Even if you just may add a comment that the patient understands, or that you reviewed with patient, or comment on the patient's physical appearance, something that makes it unique to that patient and provides the ability to demonstrate that you didn't just move from one to the other. That's really the biggest issue. It's a tool, and it's an effective tool, and it's been going on even in dictation. You use sound bites and single words to burst out a macro. All of that could be construed as cloning. It's not just specific to NextGen. So it's really important to just make sure that you are treating the patient as an individual. Some of the examples that I've seen in places where we've been is that they actually are. One place I saw in particular had nothing to do with NextGen. They were taking a Word document, and they had these set up on the patient, and they were actually storing the Word document, the full Word document in the EHR. And they would move it from one patient to the other. That was great and fine and dandy, but occasionally they forgot to change the patient's name. Now that's cloning. I think anybody, if you look at it, and by the way, this was an excellent group of physicians. They were very, very effective. I've seen Word documents being used in multiple locations, not just one group, so it's not a matter of that it's any single group. Everybody has good intentions. You want to treat the patient. In this particular case, a lot of time was spent on those documents. They thought they were beautiful. They were beautiful. You just had to make time to make those changes. And when you're doing something that's including a patient name, or as we talked about, vitals or medications or anything that's in there, and you think you're going to override it and change it later, you're going to forget. And that's where cloning comes into play.
Thank you, Cindy. Next question. One issue with performing the exceptions is that NextGen has many radio buttons, but today there's no way to unselect a radio button. If the question was not asked, when will NextGen allow the ability to clear specific radio buttons?
I'll go ahead and take that. This is Kathy. I believe, and I want to verify this, so we'll follow up if we get the specifics of who asked this question. It's a setting in the system practice template on whether or not you can clear the radio button once it's chosen. So for example, if I hit yes, and I don't want it to have anything in it, I can hit that yes again and it will clear out, but it is a setting. And I believe that just got added not too long ago in one of the system and practice templates, but I want to verify that I'm remembering this correctly.
Yeah, I believe Kathy's right. This is Cindy. It is something that I believe is also their version specific. So we will get back to you on that functionality, where that's at, and what version that's in.
Okay, perfect. Thank you, guys. We will send some follow-up with that in our email when we send it along with slides and a recording. So great question, Eric. Thank you. And it looks like that's all the questions for right now. We're going to hang on and be available here for a couple more minutes in case anybody's still typing a question. Otherwise, as always, feel free to, if you think of any other questions, email anybody you see up on the screen or reply back to my email when I email out the slides and recordings. We're here to help, so please never hesitate to let us know if you have questions. Again, follow us on social media. You can ask questions there too. And follow our blog. We now have a blog online that this week Lindsay is going to be writing on about millennials in healthcare. So that one should be an interesting one. So you can head to our website and subscribe to our blog there. Thank you, ladies. I appreciate your help today, and thank you, everyone, for attending.
All right, thank you, everybody.
Thank you.
Oh, looks like we have another question. If the provider or patient does not fall under Medicare or Medicaid, who does the potential fraud get reported to?
I'm sorry, I was muted. Yep, can you go ahead and repeat the question for me?
Sure. If the provider or patient does not fall under Medicare or Medicaid, who does the potential fraud get reported to?
So in order to be actually going through, so what Kathleen Sebelius actually pointed out in her letter is that they're actually turning over all fraud cases to the FBI, and they actually have some open right now that they're going into. So even if they aren't Medicare or Medicaid, the fraud still gets reported to the Department of Justice and goes all the way through, so it will end up in the law enforcement's hands. So you still have to be careful no matter what. I did mention the RAC specifically, but even if you aren't getting audited by RACs, there's still other ways, like I said, that can be identified with the cloning, and it still will end up, the provider will be accused of healthcare fraud, and it will end up going to the Department of Justice or to the FBI or other law enforcement.
Thank you, Lindsay. And thanks for the question, Sean. Okay, well, it looks like that's it. So I'm going to go ahead and end the webinar. Again, thank you, everyone, and have a great day.
Thank you so much.